So, good morning, one and all. First of all, I would like to thank the NAPCON organizing committee for inviting me to share my view and experience on interpreting the ILD radiology. So, without wasting much of time, as the time allotted to this topic is very less because ILD is a huge ocean. The two radiology is very important, in diagnosis and also in managing all the ILD subsets. So let's begin with this talk on this HRCT versus chest X-ray in the screening of ILD and ABPA. So as you know that imaging techniques are the essential component of diagnostic process for any of the interstitial lung disease but that we see in day-to-day practice. The imaging techniques are generally considered to be non-invasive and can provide insights into both diagnosis and prognosis of the patients, with serial imaging having the potential to assess the disease progression. So, as you all know that as a pulmonologist, chest X-ray is one of the most important initial investigation that we do for most of the lung diseases. In the same way, even ILD also, chest X-ray may be useful in identifying the patients with ILD as an initial part of investigation and are frequently the initial indicator of an ILD. Comparison of one's previous chest X-ray to the current one is very important in helping to identify the radiological abnormalities and to confirm the presence of some progressive lung disease. A diffuse reticular pattern or a ground glass opacity are the most common finding in patients with ILD in their chest X-rays. So these are the different patterns of different radiological patterns that you see in chest X-ray when you are dealing a patient with ILD. As the name indicates, these are the linear opacity, that are line-like linear lacy opacities seen in the patient's X-rays. Reticular opacities, reticular with honeycomb opacities, nodular shadows, reticular shadows. These are the different patterns of radiology that you can expect in patient with ILD in a chest X-ray. This is the same X-ray. You could see the reticular along with some nodular opacities, along with the aspect opacity in this patient, predominantly distributed in the mid and lower zone. Here you could see the nodular opacities, sparing the apices. You can see the nodules all over the lung fields, including upper, mid, and lower zones, predominantly involving the lower zones. You can see the variation of the size of nodules. Lower lobe nodules, lower zone nodules are more or larger, and some coalescent nodules also seen. Here you could see the linear opacities along with some nodular opacities in the X-rays. The diagnostic accuracy of any chest X-ray in suspected ILD is around 80%. However, chest X-ray can appear normal in patients with ILD and are considered so inferior to HRCT in the diagnosis and prognosis of ILDs. That's why normal chest X-ray should not eliminate the possibility that an ILD is present in appropriate clinical context. So let's come to the most important part of investigation in ILD is HRCT, that's high resolution computer tomography. It's a more sensitive modality of detection of ILD, particularly in ILD in early phase also, than a chest X-ray or a conventional chest computer tomography, and is considered central in the diagnosis of all the interstitial lung disease. It also allows for the recognition of abnormalities which may not be apparent in the chest X-ray in the initial phase and may lead to either earlier diagnosis of an ILD. It also helps in identification of sites for bronchoalveolar lavage. Even though BAL gives you some clue, it may not help you to confirm the diagnosis, but it gives you some clue that what form of ILD you are dealing with. For example, if you are dealing with a case of sarcoidosis, the BAL will have a predominant lymphocytic BAL indicates that we are dealing with sarcoidosis ILD. So if you are getting a patient with a neutrophilic predominance BAL, you can get a conclusion that you can somewhat conclude that the patient that what you are dealing with may be a idiopathic induced pneumonia, maybe a NSIP or a UIP pattern. And it also helps in the identification of site for a lung biopsy, because you can't do a lung biopsy in a more fibrotic area that leads to more complication. At the same time, you may not get a proper pathological guidance that will give you a clue that what form of interstitial lung disease you are seeing in that patient. So it also helps in the site and also guide the treatment strategies and also helpful in predicting their treatment outcomes. So these are the recommendations that you should ask for the patient before asking for a HRCT. So HRCT, this is the basic recommendation they should ask. Non-contest examination preferably, supine and inspiratory CT has to be asked. It should be a volumetric question. It should be sub-millimetric collimation, less than 2 millimeter. That gives you more detail regarding the pattern of ILD, what we are seeing in the CT scan. Expiratory CT, either volumetric or sequential. This is particularly useful when you are expecting, air trapping, when you are expecting a small airway disease, For example, if you are dealing a patient with hypersensitivity pneumonitis, if you are dealing a patient with something that is related to small airways, for example, bronchiolitis related ILDs and all, RBLD and all these things. So if you are expecting air trapping, it's better to ask for a expiratory prone CT, expiratory CT, and prone CT also. It's an optional. Inspiratory, it should be either can be taken as a volumetric or sequential. The recommended radiation dose is 1 to 3 MSV. It's a reduced dose only. Please avoid all the ultra low dose CT scan because it will miss out all the patterns and you may miss the diagnosis of ILD, particularly if you are seeing the patient early phase. Consider CTPA also if you are thinking of embolism along with the ILD. If you think that embolism is one of the comorbidity in ILD, if there is acute respiratory worsening in a known ILD, you can ask for a CTPA to look at the vasculature. Is there any embolism is there or not? So before interpreting the CT, you should know at least some part of lung anatomy. These are the secondary pulmonary lobule. You could see this secondary pulmonary lobule is the smallest functional unit, approximately of size 1 to 2.5 centimeter. It's made of arsenic. As you see, this is the visceral pleura. This is the interlobular septa. You could see the bronchioles. You could see the broncho. This would see the vascular structure, the arteries and veins. So this same appearance could be seen in the CT. So most of the patients with ILD, they will have the involvement of interlobular septa. There will be thickening of interlobular septa will be there. And all the distribution of the radiological patterns will be commented based on this, secondary pulmonary lobular anatomy. That's why it's very important. So as you know, the centrilobular area, this is the area which is separated by a terminal bronchiole, centrilobular artery and a vein. So pulmonary vein and lymphatics is predominantly distributed on the septa. You could see that. Once again, I'm telling this is the visceral pleura, this is the interlobular septa, this is the terminal bronchiole, this is the vein, this is the artery, and all the vein and lymphatics will be distributed along the septa. So what is the basic interpretation? How do you interpret a HRCT normally in any case of ILD? It's very simple. First of all, you should identify the pattern. What pattern of ILD you are, what pattern of radiological finding you are seeing in the ILD, whether it is an increased or decreased attenuation pattern, in what relation it is keeping with the secondary pulmonary lobule, as I already explained in the previous slide, and whether it is upper zone or lower zone dominant, and whether it is distributed more in the peripheral region or in the central region. These are the 4 questions that you should ask before interpreting any HRCT in a patient with ILD. So let's start with a high attenuation pattern. What are the high attenuation pattern? This name indicates that high attenuation pattern, anything which has a higher attenuation, which is more bright in a CT images. You could see the increased attenuation or increased lung opacity, either in the form of nodules or in the form of reticulation or in the form of ground glassing or in the form of consolidation. Let's have a look each of this. So what are the nodules? As the name indicates, nodules are sharply defined, discrete, nearly circular opacity in the lung. Its size ranges from 2 to 30 millimeter. So once again, we can classify the nodules based on their distribution. That's what initially I told you. The lobular anatomy is very important. You could see this is the random nodules. It is not keeping any relation with the secondary pulmonary lobule. The nodules are randomly distributed. So you could see as it is not keeping in relation. Here you could see the centrilobular. If you consider this as a secondary lobule, the nodule is distributed, nodule is located exactly in the center of the lobule. That is a centrilobular nodules, either as a single nodule or group nodule. And second is perilymphatic, along the septa. You could see the nodules are distributed along the septa or along the bronchovascular bundle, that you call it as a perilymphatic nodules. Each location gives you a clue that what type of ILD you are dealing with. So first we'll start with the central bundle. As you know, as the name indicates, the nodules are distributed exactly in the center of the secondary pulmonary lobule with the CT. So if you see here in the CT, there are some nodules which are having a sharp, which are not having a sharp margin. You could see a very blurred margin. And moreover, this nodule is not so much dense. That's why we call it as a ground glassing nodules. And the nodule location is also centrilobular. So it is commonly seen in hypersensitivity pneumonitis. And also you could also see this type of lesions in the RBLD, that is respiratory bronchiolitis ILD. And also you could see in TB, that is infectious bronchiolitis, either in a TB or bronchopneumonia. All these patterns you will see centrilobular nodules. So in ILD, what are the conditions you will see centrilobular nodules? Mainly hypersensitivity pneumonitis, and also in RBLD in smokers, you could see the centrilobular nodules. And second, in addition to the centrilobular nodules, what other clue that if you see a stream bud appearance, which is a special synonym that is given along with the centrilobular nodules, you could see what is stream bud appearance. You could see this is a bronchiole Along with that, increased opacity. This bronchiole is actually black only. This stands out white because of the occlusion or obliteration of the bronchioles because of the exudate. That we call it as a tree-in-bud appearance because of the occlusion of the bronchiole with the thick inflammatory exudate. So these are dilated, impacted mucous or pus-filled central lobar bronchioles. That's why you see the density and it gives appearance like a budding. And that shows that endobronchial spread of infection. You may get this in TB, not only in TB, but may be seen in any invasive or fungal pneumonia. It may be seen in non-infectious condition also. The list goes on. So next we'll deal with the perilymphatic nodule. As the name indicates that these nodules are located around the lymphatic region. So basically along the septa, you could see that this is the septa. You could see the septa should be smooth. It should be irregular septa is there. And all the bronchovascular structure along the vessels, you could see the nodularity. So this is a perilymphatic nodule. Classically, you see in sarcoidosis. If you are thinking of infectious disease, maybe all the disease which spreads to the lymphatics, you may get the perilymphatic nodules, that too in TB also. And if you see unilateral, bilateral, you could think of a lymphangitis carcinomatosa, and also in some case of silicosis and cold locus pneumococcal, you get a perilymphatic nodules. And as I already told you, random nodules, these nodules doesn't relate with their with your secondary pulmonary lobe anatomy. Nodules are randomly distributed, usually seen in hematogenous spread of infection. You may get in hematogenous metastasis, you may get in miliary tuberculosis, fungal infections. Why I put in this ILD is because in case of Langerhans histiocytosis in early nodular stage, you will see a stellate shaped nodules, that is a Langerhans histiocytosis. You will see a stellate shaped nodules that is randomly distributed predominantly in the upper and mid zones of the lung. So that you should note. And reticular pattern, this is also once again an increased attenuation pattern. It is nothing but this reticular pattern is nothing but the lacy appearance in the lung. It's due to the thickening of interstitium by the fluid or fibrous or infiltration. So basically, once again, you can divide the reticular appearance into, you can see this reticulation. It is irregular. This is regular. It is rough. It is smooth. So if you can differentiate into smooth reticular appearance or nodular appearance. Now smooth you will get in a case of fluid accumulation, in case of pulmonary edema. Nodular you will get in a case of lymphangitic spread of carcinoma, as you see in lymphangitis carcinomatosa, and also in case of sarcoidosis. So once again, if you see interlobar septal thickening, you could see how the thickening is, whether it is a smooth or it is nodular or it is irregular. If it is irregular along with lung distortion, think of sarcoidosis, asbestosis, UIP, that is IPF, most commonly you will see as, and fibrotic HP, that is chronic HP, you will see all these things. If you see there is no lung distortion, but it is smooth interlobar septal thickening, if it is thick interlobar septa, most common causes pulmonary edema, second into cardiogenic causes. And lymphangitic tumor, lymphoproliferative disorders, amyloidosis, and venoculitis, PVOD, is one of the most important differential diagnosis for a patient with a cardiac failure. You could see all the curly lines, you could see all the smooth thickening will be there, similar to a cardiac failure. But when you analyze the patient, this patient will have a PVOD and organized pneumonia also. And if you see a smooth septal thickening along with ground glass opacity, then it gives you a clue that you are dealing with a crazy paving appearance. The crazy paving is a classical terminology as given in the CT reading, that is nothing but you will see a interlobar septal thickening in the background of the ground glass opacity. That means that ground glass is acute lesion, interlobar septal is a chronic lesion. That means acute on chronic lesions. If you mix it, that will see a crazy paving pattern. Classically seen in pulmonary proteinosis, but you may get in other conditions also. Nodular appearance, this nodular appearance is, if you see nodular appearance of interlobar septa, then you could see the perilymphatic by sarcoidosis, lymphangitic tumor, lymphoproliferative disorder, silicosis, as I already described in the previous slide. Next, come to the once again most common radiological finding, that is a statutory finding when you are dealing with a patient with ILD, is that ground glass opacity. That's a hazy increased attenuation, but not obscuring the underlying vessels. Ground glass nothing but through the glass if you see the structures. That means that there is opacity, but it is not completely obscuring the underlying vessels. Interstitial fibrosis as well as alveolar filling, either it fills with the fluid or for anything, blood. So that will produce a ground glass. Seen in acute pulmonary edema, but may be seen in any fluid. That may be seen in hemorrhage, alveolar hemorrhage, or it may be seen in inflammatory exudate that you get in a pneumonia. And also you could see the same appearance in chronic HP pneumonitis or acute HP pneumonitis. Typically in acute HP pneumonitis, you will get a ground glassing. And organizing pneumonia, NSIP, one of the most common interstitial pneumonia that we see in day-to-day practice in the background of CTD. In that also, if you see ground glassing, you can get a clue that the patient is having NSIP. And bronchoalveolar carcinoma. As you know that alveolar carcinoma can present typically as an infectious sequelae in the HRCT. It can present as a consolidation, it can present as a nodule, it can present as a miliary remodeling. So basically alveolar carcinoma has to be considered as one of the DD when you see a ground glassing. So here you could see a dense consolidation surrounding that ground glassing. Here you could see a patchy areas of ground glassing that is almost distributed all over the lung fields. As you see, this is a case of pulmonary edema. This is a case of bronchoalveolar carcinoma presenting as a consolidation with surrounding ground glassing. And once again, consolidation, that's a commonest pattern, radiological pattern you see in day-to-day practice in pneumonia. But as you know that consolidation doesn't always indicate you only you are dealing with a true infection. You may get a consolidation in other non-infectious condition also. And ILD is one of the conditions that you should note, because in organizing pneumonia, the present will be a consolidation. Here you could see the consolidation, nothing but airspace opacity is nothing but filled with airways are filled with or alveoli filled with the blood, pus or fluid cells. Classically, you will see an air bronchogram. Air bronchogram is described both in X-rays and CT. You could see here in the periphery of the lung distribution, you could see some airspace opacity consolidation along with the ground glassing. And here you could see the same patient, it's followed up after 2 to 3 months. You could see that there is a airspace of consolidation predominantly distributed along the vessels, along the bronchosal area, sparing some amount of peripheries. And you could see this distribution is very close to the vessels or very close to the airways. So seen in organizing pneumonia. We have described all the high attenuation pattern, the patterns which blinks you, which have a bright attenuation. Now we are going to deal with the low attenuation, that is somewhat dark in the HRCT. So you could see this in emphysema in case of lung cyst, bronchiectasis and honeycombing. So you could see these are the honeycombing, these are the traction bronchiectasis, lung cyst and central lobe emphysema. As you know that emphysema, secondary pulmonary lobe, one second anatomy, you could see that each secondary pulmonary lobe, you could see the low density dark images there. You could see that this is a central lobular emphysema and this is a paraseptal emphysema. As you know that emphysema is predominantly distributed along the edges of the lung, along the septa of the lung. That is a paraseptal emphysema. Here you could not see the anatomy of secondary pulmonary lobe. There's a jet black. You could not differentiate anything. So that indicates that it is a pan-acinar emphysema. So you may ask one question, sir, why you are describing emphysema when you are dealing with a patient with ILD? Because as you know that there are certain ILD which can present you with the high lung volumes. There are certain ILD which can present like emphysema. The commonest, one of the rare thing that you see in day-to-day practice is CPFE, that is combined pulmonary fibrosis with emphysema, where you see more of emphysematous changes in the upper lobes and more of fibrotic changes in the lower lobes. And cysts are nothing but they are defined as radiolucent areas with the wall thickness of less than 4 millimeter. You could see what are the different cysts that you see in different ILDs. Here you could see the cyst is seen, but the cyst is uniformly sized, evenly distributed, and is located close to the periphery of the lung. The description is the cyst is uniformly sized. There is not much of difference between the size of the cyst and both the lungs. It is symmetrically distributed, involving the periphery of the lung, classically seen in LAM. One of the commonest cause for recurrent pneumothorax in the pre-menopausal woman that you see in day-to-day practice. So this is the thing, such that, and here also you could see a same patient with a pneumothorax. Okay, and here the difference, but this is also cystic lung disease. You could see the cyst wall, the thickness of the wall is very high. You could see the cyst is well defined, evenly spaced. It is poorly defined, thick wall, and it is irregular. This is the difference. And you could see the normal lung between, and you could see this past the peripheral part of lung. Can you see that? See the past the peripheral part of the lung. This is a thick walled, irregular, bizarre cyst, predominantly distributed in the upper lobe, past the peripheries, and also associated with some nodules along with the cyst. You could think, if you are dealing with the smokers, you could think of LCH. So the difference between LCH and LAM is a smooth, thin-walled cyst, evenly distributed all over the lung field, involve the peripheries, most common present in pneumothorax, whereas LCH is a thick-walled, irregular walled cyst, bizarre shaped cyst, predominantly distributed in the upper lobes, sparse the peripheries in the lower lobes, and also associated with the nodules. So these are the common cystic lung disease that you see in a patient with the interstitial lung disease. And once again, this is one of the cysts. You could see this cyst wall also very thin, and this cysts are evenly sized, and it's a sparse cyst. You don't find a lot of cyst in the lung. There are sparsely spaced cyst, and this cyst actually abuts the vessels that is close to it. This is very classically seen in Sjogren syndrome. If you see cyst along with the ground glass, along with the reticular opacity, at the background of symptoms of Sjogren's, you could think of LIP, even without the diagnosis. This is a lymphocytic interstitial pneumonia, that is LIP, that you see in Sjogren syndrome. Here you could see the cyst is large, bizarre. Yeah, of course, it's not ILD. It is a different disease. It's a Burtock-Dubé syndrome. Just for a completion, say included in this slide. And most important thing that you should understand is a honeycomb lung. Honeycombing is one of the commonest presentation of any fibrotic ILD in the terminal stage. Honeycombing is defined as the presence of small cystic spaces with irregular thick-walled walls composed of fibrous tissue. Honeycomb cysts often predominate in the periphery and subpleural lung, regardless of their cause. As you know that honeycombing is common in IPF, but you could not deny that any fibrotic interstitial lung disease can present honeycombing, but honeycombing occurs so early uncommonly in IPF that you should remember. And subpleural honeycomb cysts typically occur in the several contiguous layers, like a chain pattern. If you see a evenly thick-walled cyst-like appearance, small, and it is like a chain lacy pattern, you can easily come to a conclusion that you are dealing with a honeycombing. So honeycombing, as I described, you can see this type of pattern in IPF, UIP. You could see the same pattern in rheumatoid arthritis and scleroderma, some drug reaction, asbestosis, and also end-stage epistemology. That's a chronic epistemology, and also some patients with end-stage sarcoidosis, fibrotic sarcoidosis. This is a patient, you could see, this is the patient with IPF. You could see the traction bronchiectasis here. You could see that some layers of honeycombing, and there are some bizarre cysts like this. These cysts are not typical of honeycombing. This is nothing but as the disease is progressive one, you could see the coalescence of honeycombing can give some form of larger cyst, which is not very typical of honeycomb cyst, but you may get this type of cyst in some patients who have a progressive disease. And these are some important salient CT findings in any of the interstitial pneumonia that you should remember. If you are dealing with the usual interstitial pneumonia, the classical teaching will be a fibrotic changes will be there. You could see a lower lobe typical subpleural honeycombing along with the traction bronchiectasis or bronchiectasis. If you are dealing with NSIP, you could see more of ground glassing than the fibrosis. If you are seeing with RNS pneumonia, the distribution will be more peripheral, symmetrical shadows, and this consolidation airspace is distributed predominantly in the bronchovascular region. If you are dealing with the DAD, diffuse cellular damage, you could see more of diffuse ground glass opacities. If you are dealing with the RBLD, that's a respiratory bronchial ILD, more of central lobar ground glassing nodules, as I already described that in the previous slides. If you are dealing with the DIP, which is one of the sequelae of RBLD seen in smokers, you could see more of lower lobe ground glass opacities along with central lobar nodules also. If you are dealing with the LIP, as I already told you, you see perilymphatic ground glass opacity along with the nodules with some typical cysts that I already described in the previous slides. Okay, the commonest two interstitial pneumonia but that we see in day-to-day practice is UIP and SIP. Let's have a look at this. So in UIP or in IPF, you don't have to do biopsy in all the cases. CT will give you a confident finding. What are the confident findings you should look for in a CT in a patient if you are dealing with a UIP, that too in an IPF patient? If you see a subpleural or basal predominant distribution, or often heterogeneous distribution with honeycombing, with or without traction bronchiectasis or bronchiolitis, you are very sure, you are very confident that you are dealing with a IPF or UIP pattern. But if you are seeing a same distribution, subpleural basal predominant distribution, heterogeneous distribution, reticular pattern will be seen, traction bronchiolitis pattern is seen, but you don't see honeycombing. If you are in that situation, then you can name it as a probable UIP. This patient may either turn into a UIP or turn into other diagnosis after your histology. So other things like indeterminate for UIP, like you see all the basal distribution will be there, but you don't see any other features like honeycombing or something like that. If you are seeing other lesions like cavity or cyst or any nodule, central nodule, stain bud appearance, or any pleural plaques and pleural environment, esophageal dilatation, all these things are totally against the diagnosis of UIP. If you are seeing any of these findings, don't think of UIP as a first diagnosis. You rule out other things, then think once again as a UIP. So according to zonal distribution also, we can come to a conclusion what ILD you are seeing. So basically, there are some ILDs which are predominantly distributed in upper zones. That is silicosis, colocus pneumoconiosis, sarcoidosis, ankylosing spondylitis, and histiocytosis X. This is nothing but the same thing, Langerhans histiocytosis. All these things predominantly involve the upper lobes, that is the upper zones. That's why based on the zones only, you can come to a conclusion that what type of ILD you are dealing with. And lower zones, what are the things that you should keep in your mind is chronic interstitial pneumonias, any chronic interstitial pneumonias. If you are dealing with idiopathic interstitial pneumonia, either it is a NSIP or UIP, either you are dealing with a IPF or UIP due to other conditions, or NSIP due to underlying CTD, the predominant distribution will be in the lower zones. And also asbestosis and fibrosis due to collagen vasculitis, as already described, predominant distribution in the lower zones. So in addition to upper lower zone distribution, so you can also see whether the lesions are more involving the periphery or the central part of lung. If it involves the central area, think of pulmonary edema. Actually, pulmonary edema also is interstitial because it is nothing but the fluid filling the interstitium. It is reversible one. Pulmonary edema, pulmonary alveolar proteinosis, or pulmonary alveolar proteinosis, all these things involve central area, and some lymphogenic tumors, particularly Kaposi sarcoma and lymphoma, it involves central area. Peripheral areas, as I already told you that some chronic yeast pneumonia, the peripheral consolidation is typically seen in chronic eosinophilic pneumonia. So in case of chronic eosinophilic pneumonia, it's considered as a reverse pulmonary edema. You could see the consolidation or aspects of basically predominantly in the lung ridges. So that is one of the clues. And organizing pneumonia also, you could see the periphery of the lung is more involved when compared to central region. And chronic eosinophilic pneumonia, has already described that. So when you see associated finding along with the pure lung disease, you could also get a conclusion. We'll get some clue that what type of ILD you are dealing with. If you are seeing pneumothorax, then you can just think we are dealing with a lymphangioma, you are dealing with the LCH, or you are dealing with the end-stage honeycombing. That shows that is a fibrotic ILD that gives you a cyst that breaks into a form of pneumothorax. And if you are dealing with a pleural effusion along with ILD, even though it is not very common, you could see this pleural effusion in lymphangioma. In lymphangioma, if you see pleural effusion, typically a chylothorax pleural effusion. So that gives a clue that you are dealing with a lymphangioma. And also collagen vascular disease. Sometimes in some collagen vascular, you get a pleural effusion. Typically in case of SLE and also rheumatoid arthritis, you can present as a pleural effusion. And lymphangitis carcinomatous and pulmonary edema. All the cases will get a present as a pleural effusion. Pleural thickening is very rare. You will get in the case of collagen vasculitis, typically in sarcoidosis. Typically in scleroderma. If you get in scleroderma, pleural enlargement is very rare, but you may get pleural thickening in most of the patients with scleroderma along with ILD. So that you should understand and you should remember that. And asbestosis, that they can present as a plaques and diffuse pleural thickening will be there along with the ILD. That's what we see. So if you are seeing adenopathy, if you are being lymphadenopathy, then you could come to a conclusion. In case of standard chest X-ray, if you are seeing such a large bumpy lymph nodes, calcified nodes, common thing what you see is a sarcoidosis. If you see bilateral hilar enlargement, irregular, potato tumor appearance, all these things, think of sarcoidosis. If you see a calcified appearance, nodules, calcified nodes are there in the hilum, think of silicosis. And lymphoma also, you'll get a lumpy, bumpy nodes in the hilum region. And under lymphangitic carcinoma also, you'll get a hilar adenopathy. If you are dealing with a CT scan, because CT gives you more clue about mediastinal or hilar adenopathy, because X-ray will pick up the nodes at a larger size, CT picks up the nodes even in smaller size. It's not surprising to see lymph nodes even in NSIP and IPF also. You may get a non-specific lymph node enlargement in case of IPF and NSIP. You may get in a case of Hodgkin pneumonitis. You may get in case of collagen vasculitis. You also get in a case of lymphangiomatosis. Okay. Finally, I'll show you some slides that gives you clear picture what is an UIP and what is an NSIP. Here, what is a typical UIP? As I already told you, you see the distribution. It is predominantly in the periphery and in the subpleural location, predominantly in the lower zones. You could see the classical honeycomb lesion that I described. You could see the lacy appearance, typical size of the cyst, which is very classical of honeycombing. You should the layers of the cyst, that is classical of honeycombing. And also you could see the traction bronchiectasis and bronchiectasis. Bronchiectasis is the proximal part, bronchiectasis is the distal part. The same thing, if it extends up to the periphery, that it comes as a bronchioles. You could see bronchiectasis, bronchiectasis, along with honeycombing, that you are very confident that you are dealing with a UIP. So this case is a probable UIP. Here you could see, I'm not seeing any honeycombing as such, but I could see some peripheral subpleural involvement. There are some reticulations there. Okay. And there are some cystic changes are there, but they are isolated. They are not group cyst. They are not line-like appearance, as I already described in case of honeycombing. And this is the case of NSIP. As I already told, NSIP gives more of ground glass opacity. Here you could see NSIP, typical subpleural location is there. Same thing. Predominantly lower environment, symmetrical subpleural location is there. But you could see the classical, ground glassing. You are not seeing any traction bronchiectasis. You are not seeing any evidence of honeycombing. You are not seeing any other airspace opacities. But sometimes in 25 to 40% of cases, you could see the subpleural sparring. That means that subpleural part of lung is spared and you see the lesion just above that. So that is very classical of NSIP. And the same NSIP pattern, if you're not treating it properly, if you're going for fibrosis, the same thing, it is called as fibrotic NSIP. Here you could see no honeycombing was there. You could see the distribution of the lesion. It is not subpleural. It is actually a peribronchiolar. It is more in the central region, not so much in the peripheral region. You could see the traction bronchiectasis, but you are not seeing honeycombing. So much of fibrosis is there, but you could not see the honeycombing. That's actually totally against the diagnosis of UIP. So it comes under NSIP. So let's discuss some CT images and some X-rays related to ABPA, which is also included in my topic. So ABPA, allergic bronchopulmonary aspergillosis. So what are the different stages of ABPA as per the chest X-ray findings? Acute remission, exacerbation, steroid dependent end stage. There are 5 stages are there. In acute stage, either it may be normal X-ray or you may get a multiple patchy fleeting opacities will be there in the X-ray, or you may get a finding related to the mucoid impaction because a thick viscid mucus that occlude the bronchus that shows as a non-infective consolidation because of the blockage. And at the same time, in case of remission, there is a significant resolution of infiltrates will be there that already diagnosed and clearance of mucoid impaction. In exacerbation, once again you see the reappearance of infiltrates will be there in the X-ray. In the steroid dependent, you could see the resolution of pulmonary infiltrates, mucoid impaction, along with the fixed opacity. There are some opacities, fibrotic changes, traction bronchitis, and bronchiectasis, which is permanent in a steroid dependent ABPA. In end stage fibrotic ABPA, you will see the evidence of bronchiectasis, predominantly a central bronchiectasis. You will see evidence of fibrosis and also pulmonary hypertension. There are certain transient changes you see in a normal chest X, that is patchy area of consolidation, radiologic infiltrates secondary to mucoid impaction, either in the form of toothpaste appearance when a single bronchus is involved, or gloved finger appearance when the multiple bronchus is involved, occluded with a thick mucus, or if it shows a collapse, either to be a lobar or segmental collapse. These are the common findings. Whereas a lot of uncommon findings were there. Bronchial wall thickening, which can present as a tramline appearance. Normally, you could not see any bronchi in X-ray. When the bronchi will be seen, because the wall will be very thin, could not be picked in X-ray. If the wall is thickened only, you could see a white line that appears as a tram line along with the air inside. And air fluid level when the dilated bronchi will be seen. Perialar infiltrate simulating adenopathy can be seen. A massive consolidation, either penial blood can be seen. Pleural effusions are very rare, but you could not deny that ABPA, in some portions of ABPA, it can present with a pleural effusion. So that also is one of the uncommon finding, which is considered as transient changes. There are certain permanent changes you see. Parallel line shadows representing bronchial widening, ring shadows 1 to 2 cm in diameter representing a dilated bronchi NF. There is a bronchiectasis thing. And pulmonary fibrosis, fibrotic scars predominantly distributed in the upper lobes with the cavitation can be seen, which are the permanent changes. You see more of fibrotic and chronic changes like bronchiectasis and fibrosis. Uncommon like pleural thickening, you may get a secondary aspergilloma formation. In a cyst of bronchitis cyst, you may get a scar. Okay, this is a patient that was describing. You could see ABPA can present as a zone of consolidation. It can present as a zone of obstruction because of mucoid impaction, classical gloved finger appearance. So these are the different varied presentation. Here there is a complete obstruction of the left upper lobe. You could see the complete collapse of the upper lobe along with the traction of the trachea. And after the bronchoscopic treatment, after the clearing, you could see the re-expansion of the lung. Here, chronic case, you could see the central bronchi, dilated bronchi, cystic changes are seen. Here also you could see the cystic. And what are the CT findings that you get in ABPA? So chest X-ray is not very specific for the patient with the ABPA. To diagnose ABPA with chest X-ray is extremely difficult. It is totally non-specific. Whereas CT thorax gives some clue. So if you are seeing a central bronchiectasis, that gives some clue that you need to work up for ABPA. Extensive usually involves 3 or more lobes. If you are seeing a mucus plugging, which is usually hypodense lesion that is seen in the lung because of the obstruction. But note this point, the mucus plugging obstruct the lung and cause the lung to collapse, which appears as a hypodense lesion. Whereas the mucus inside will be hyperattenuated mucus, which is very classical for the diagnosis of ABPA. But unfortunately, you will see this finding only in 20% of patients. And you also see some evidence of bronchiolitis also. You could see, as I already described, treen bud appearance, infectious bronchiolitis also. You get treen bud appearance in ABPA also. And atrial disease concern mosaic attenuation can be seen because of air trapping. Same thing. You could see a bronchiectasis involved the central region. You could see the central bronchiectasis. You could see all these things. Extensive bronchiectasis, cystic bronchiectasis. See this ABPA. And this was the point I was describing. The presence of high attenuation mucus because of the dense mucus plug, which is visually denser than the paraspinal skeletal muscle. You can compare the skeletal muscle. That is so much dense than the paraspinal skeletal muscle, that mucus. So that is indirectly pathognomonic for ABPA. But you may not see this finding in all the patients. Here you could see there are some sentilobar nodules, there are some focal area of a nodule surrounding ground glassing. Along with that, you could see here, the same patient, you could see here, there is a dense lesion is there. There's a dense lesion. You could see the density that is actually hyperattenuation because of the mucus obstruction along with the collapse. If you see any lesion like that, you can come to a conclusion somewhat that you are dealing with the ABPA. And once again, the same patient, mosaic attenuation seen along with the cystic bronchitis. Okay, at the end of my presentation, assessment of any diffuse parenchymal lung disease, best thing is that you should know a pulmonary anatomy for interpretation. Systematic approach for the patterns of abnormalities and HRCT, as I described already in my presentation, is very good for essential, is very good and essential for a good diagnosis. Always integrate your clinical findings, HRCT images for better diagnosis. And go for a biopsy in HPE when in doubt. Don't go for a biopsy in all the cases. When in doubt, then you can go for it. And ABPA can present with the diverse radiological vision. Patients with ABPA can present with central bronchitis as well as peripheral bronchitis, but presence of ham can give you more, evidence that the patient you are dealing with the ABPA, but that is seen only in 20% of cases. With this, I'm just ending the presentation because the ILD discussing radiology is very difficult in just a matter of 20 or 30 minutes. So we will see you in some other discussion in any other meeting. Thank you, Ananda.